Okay, great. Well, good afternoon, everyone. The first webinar in our series is the evolution of service delivery for people living with intellectual and developmental disabilities in the United States. And I think this is really a very important beginning webinar for everyone to understand just why we are at the point we are in our service delivery system, and I'll go much more in depth as we go through it. For those of you who are not familiar with me, I'm Tom Wiles. I've just celebrated my 50th anniversary in the field. I started out in direct service. You can see on the slide I've done a little bit of everything. I also was a consultant and a trainer in the area of deinstitutionalization and the integration of preschool and school-age children. I was the president and CEO of a nonprofit for 33 years that converted from a center-based services to totally integrated community-based and employment services. And for the last 5 years, I've been working for the Department of Labor, Justice, several provider associations, DD Council, and directly with numerous states. In my work, which is the most relevant for you as the CEO, we converted our workshop to community integrated employment. We moved our facility-based services to community-based services, our early intervention to typical daycare settings, our private segregated school back into the public schools with continued technical assistance from my staff. We downsized our ICF residents. We had a whole slew of them, to small homes and apartments funded through waiver. And over time, we sold all of our facilities. We had several large schools that we sold and began to lease office space. But all of our direct services were totally community-based. And I know a lot of people, as you begin in the transformation process, there is anxiety about how are we going to do this. And over the course of this coming year, Jenny and I are going to share with you a lot of really simple, straightforward techniques about how to make the transformation. You know, when we began this process, I guess in the mid-1980s, we were all by ourselves. We had no role models. We had no direction. We just felt, and you'll hear the story in a later webinar about how we came to the conclusion that we needed to move to being facility free. But on the other side of the transformation process, we were very successful. And I really want to share that concept with you, that this isn't a losing proposition. We grew from a single state, we were in Washington, D.C., to 5 states. When we started out, we had a small $300,000 budget. And when I retired from that organization, we had a $33 million budget. I went from 30 staff to 900 plus. I went from just one board of directors to 8 interrelated boards, and consequently from one corporation to 8 corporations. So it was an incredible amount of growth and success. And the people that we were serving went through the transformation with us. And as I know some of you who have started the process and have people more in the community, the change in life for people was just astounding. That, you know, the goals personal goals that they were able to meet was far beyond any expectation that we ever had for them at the end. For this webinar, there's 4 simple objectives. We're going to talk about the evolution of services in our country. Started as institutional services, we moved to center-based services, and now we're moving to community-based services. And we're going to talk about what all that means. The impact on individuals receiving services through these various models. What has driven these service changes, the legislation and litigation, especially in the last 30 years or so. And what does this mean for you as a service provider, the impact on states and the state agencies, and for the individuals transforming to community-based services and their families. So, before the 1880s, services were, provided by people of goodwill. There was no really organized services paid by the federal government. The country was very young, and there really wasn't much help for people. In the 1880s, some American cities even had beggar laws and ugly laws where it was illegal for any person who is diseased, maimed, mutilated, or deformed in any way as to be unsightly or disgusting to expose themselves to the public. So, people were hidden away. Parents were ashamed of their children. They were stigmatized. In 1848, the first residential institution for people with mental retardation, now intellectual disabilities, is founded by Samuel Gridley Howe at the Perkin Institute in Boston. And during the next century, hundreds of thousands of folks with developmental disabilities and intellectual disabilities would be institutionalized, many of them for their entire life. Here's a snapshot of the first institution for folks with intellectual disabilities, the Perkin Institution in Boston. The early services provided to people had a variety of missions, protection for society. Let's get these people away from us. When I worked at the institution, a lot of people were placed there as punishment. It was basically a prison. A lot of medical research was going on, medical treatment. Some of it was very abusive, as researchers were looking for ways to prevent intellectual disabilities. Some had good intentions of education and employment training, but throughout the years, regardless of what their intention was, things would go radically amiss. In 1855, the first psychiatric hospital in the United States would be founded, St. Elizabeth Hospital in Washington, D.C. It was huge. It was a city into itself. It served over 8,000 patients at one time in the 1950s, and it continued to operate till this day. As time went on, a lot of things happened. In the 1870s was the Great Recession, that even children without disabilities were found sleeping in the streets, eating garbage, dying. This was from a diary from the head sister from the organization that I became CEO of in the 1980s. So you can imagine, if this was happening during really hard times to children without disabilities, just what was happening to children who really couldn't care for themselves. And so we went from the Civil War, the Great Depression, World War I, we went through Darwinism, World War II, regardless of what the intention of some of these large facilities were for people with intellectual disabilities, they became short-staffed and gravely underfunded. When I began my career in the late 1960s, you see the ward there at the top left of this collection of pictures. That's exactly my working conditions. I would have 60 people or so in a room, wall-to-wall beds, no type of entertainment, very little clothes. I would be locked in there with these individuals, all different levels of functioning, all different ages. It was just hell on earth. And these are typical pictures from a variety of institutions. The bottom on the right is from Forest Haven, where it's a ladies' ward. And if you can see the young lady who are laying on the floor there, her foot is by a drain. This institution was known for, at least on the men's ward, where I had many opportunities to visit, that drain became important because they would come in for bath time with a hose. And all the men, there would be like 30 or 40 men there, and they would just hose them off. And they would spend their day naked in that room. So it was very disturbing. So the institutional model was typically large groups, and people were labeled with different levels of functioning. Are grouped by disability. Over here is all the Down syndrome people. Very abnormal relationships, weren't provided any kind of normal interaction with non-disabled people. Most of the time it was a focus of safety and medical, of we're going to try to keep people alive, and they had no right to risk, very overprotected, if you want to call it that, as they were locked up in rooms and not allowed out. I was in this one ward where they never had any shoes or very little clothes. No one could go for a walk. And these were children who would just spend their entire life in this building. Services were centralized. As you saw those pictures of the institution, they were cities unto themselves. They had their own laundry, their own food services. They had their own hospitals. No one left the grounds. They were isolated from the public. So when abuse and neglect occurred, no one really knew it. Occasionally, they would have simulated training sites, but they were very abnormal learning experiences. They weren't with non-disabled people. And so they really weren't getting people ready to re-enter the normal community. And they were permanent placements. There were no expectations. There were no dreams for the future. This was pretty much the beginning of the end when people were placed there. In the 1950s and 60s, the country's awareness really grows. Parents and leaders became active in creating center-based services. Let's get these people out of these large institutions and closer to the community where parents could at least go visit their children, have interaction. And President Kennedy was a strong advocate. His sister had intellectual disability, but as a sign of the time, his sister was made to have a lobotomy. His sister went to church in the neighborhood where our agency was located. She never came to us, but it was said that they were very sad that they made that decision for her. Johnson was a school teacher and helped funding for our programs, and Hubert Humphrey had a grandchild with a disability. So the momentum began to grow to change services. So a lot of center-based training through charitable organizations, through churches. This is actually the picture of my first agency that I was the CEO. It was very small. We had about 30 children with intellectual disabilities, and it started in 1956. I arrived there in 1980. But regardless of the slow transition to center-based services, segregation really remained the norm. Even in center-based services, people were segregated. It was the only option for families. Institutions were really the primary focus of care at that time. There was no right to public education, rehabilitation, or inclusion. And there were really no choices and no dreams for the future until things began to change in the 70s. In the 70s, there was a series of class action lawsuits across the country against large institutions. You had Pennsylvania, Alabama, Washington, D.C., New York, Maryland. There were many more. And the federal litigation was about that these institutions violated the constitutional rights of the people who were residing there. Public funding for center-based services in the community was up until 1980s was primarily in the institutions, but in 1982, Medicaid created a first optional waiver program, and most of you now are funded by the waiver. The waiver program was fairly unique in that Congress said that if a state, on average, could spend the same amount as they were spending for the institutional care, they could waive all of the institutional regulations. There were other regulations that evolved, but you could get away from these very institutional requirements for caring for people. That was one size fit all. Everybody got the same kind of services. And now they were saying, we could waive all that and break it down into more normal kinds of situations in the community. And today, all of the states use the home and community-based waiver through a range of funding streams. And we'll talk about that in a little bit more specifically. As you can see in this chart, over time, that from 1995 and moving forward, that funding for institutional care continued to decline over the years. And I believe today waiver funding is much more on a national average than institutional funding. So there's this trend that continues to evolve. In the 1970s, because of all that litigation, there was a deinstitutionalization movement. Let's get these people out of here. And with that, we began to move people out of ICF, MRs, in the institution and move them into the community. and we started creating fairly large group homes, maybe 8 or more people living together, center-based day programs, and sheltered workshops. So this is the beginning of the model, the center-based model that most of us have today. That took 100 years or so to finally get to, from the mass institutionalization of people. But the institutional issues persisted in the center-based model. People were in the community, but are typically not included in the community in a normal, consistent way. People are still segregated in the center-based model, where there's a lack of non-disabled role models. Most of the relationships, at least in the center, are paid relationships, staff. People don't have many non-disabled friends. It's still more of a medical model of taking care of people, not providing opportunities for risk, that we're always getting people ready. But somehow people never get ready. We really don't place that many people in the community under the center-based model. They're not within the public view, so who knows what's going on. People have very few choices and a lot of unmet dreams that, there's a lot of people who want jobs, who want to have non-disabled friends. And what I found, and I actually did this myself, I'm sorry to say, is some of the most capable people are often retained in the workshop for the sake of the workshop survival. We can't let Joey and Bill, go get a real job in the community, even though they might have a mild intellectual disability, because the whole sheltered workshop will fall apart. Our survival as a business is depending on keeping these people back. And I'm sorry to say, too, that what I realized as CEO, I bought several multi-million-dollar buildings, and I wanted to fill them up because my funding was based on putting people in those buildings. In 1972, Head Start came out with a mandate that 10% of its enrollment opportunities had to be for children with disabilities. So for the first time, it was being mandated that children with special needs needed to be with non-disabled people and to grow up in a non-disabled community. It was a big change in our country and our service delivery system. In 1975, it followed with Public Law 94-142, the Education of All Handicapped Children Act, and now it's called IDEA. And it required all public schools accepting federal funds to provide equal access to educate children with physical and mental disabilities. You had to create an educational plan for these children, emulating as closely as possible the education experience of non-disabled children. And it required a least restrictive environment that allowed a maximum possible opportunity for these children to interact with non-disabled students. And it also required students to receive employment services. So things began to change, and the expectations of parents began to change as they saw their children future changing and being part of a non-disabled community. In the 1980s became the funding and the concept of supported employment, that we can have people with fairly significant disabilities be in the workforce with a little bit of help. And it was a major change. Instead of let's train somebody maybe forever and then try to find a place for them in the community, we started to look at what skills, what interests does this individual have now. Let's take those skills and interests and place them in a situation where they can grow and have a job now, and we will train them on the job. And so a lot of things changed. At our agency, this was a big breakthrough. So this was like in the early 1980s when this occurred. And my agency, I began to send people in about 1985 to supported employment training. And I had hundreds of people in center-based programs. I had 2 large buildings that could hold hundreds of people. And our staff began to place people who were institutionalized for their whole life, from some who were dropped off when they were a couple weeks old at the institution and who were now 40 years old. They had very little social skills. They may not have even been verbal. And some of them had maladaptive behaviors and even considered dangerous. And suddenly my staff were placing them in really high visible integrated settings at minimum wage or above. And within months, they began flourishing. They were just totally different people. And that initial almost experiment at my agency changed all of us forever. And we were on our path then to the transformation process of how do we integrate all of these people back in the community with our support. So we began that process. In 1990, became the Americans with Disabilities Act. And it required equal opportunity to benefit from the full range of employment-related opportunities available to others without disabilities. It required access to public services by individuals with disabilities in the most integrated settings, and to allow folks to interact with people without disabilities to the fullest extent possible. So that was on the books for about 9 years when the Olmstead decision came down. In Georgia, a few women who had been institutionalized decided that they didn't want to be institutionalized, that they wanted to receive services in the community. And the state said, no, we're not going to do that. You have sufficient services here at the institution. Well, they won their case based on ADA, that the court said that this prohibited unnecessary segregation, that services should be provided in the most integrated setting, and that segregation included settings that were populated exclusively or primarily with individuals with disabilities, and that settings that provide for daytime activities primarily with other individuals with disabilities. So they were saying that this segregated service setting really had to end. In Massachusetts in 2013, they were one of the first states to come up with a plan to formally close the door to sheltered workshops as of 2014. It took them a little bit longer. It took them to 2015 to do that. They set a goal that people were to be in integrated individual or group employment at least at minimum wage or higher, and are in community-based day services, not center-based day services, but fully included into community activities. That we would continue to transition individuals from community-based day services, those people who went there, to integrated work opportunities that paid at least minimum wage, and that we would be phasing out any group employment settings that paid less than minimum wage. And they would set criteria for development of new affirmative or social enterprises, which means that businesses that a provider would actually operate as opposed to being out in really a typical community employment site. So that was a major change. Then in 2014, the United States sued the state of Rhode Island. The state of Rhode Island had a practice of putting people from school directly into sheltered workshops without any choice of real integrated competitive employment. And kind of bottom line, they sought relief for over 3,200 individuals with intellectual and developmental disabilities. And they were ordered to have real opportunities for real employment in the community at competitive wages and integrated day activities for non-work hours. So that was a big change. In 2014, at the same time, WIOLA was enacted by Congress. And it's the Voc Rehabilitation Act was amended. And it required a much larger role for public vocational rehabilitation agencies working with people with disability to make the transition from school to adult life, so that they were going to play a bigger role in public school system. It intended to limit the use of sub-minimum wages. It created a definition for both customized employment and supported employment. And it said that competitive integrated employment was the optimal outcome for people with disabilities. So we're really getting away from caring for people and helping facilitate them being in the regular workforce. We also established two requirements for people to be in sub-minimum wage. One, for individuals with disabilities 24 years of age and younger, must be provided with various services designed to improve their access to competitive integrated employment. Transition services, voc rehab counseling, career counseling, before they could be placed in a sub-minimum situation. And that no employee with a disability, regardless of age, to be paid a sub-minimum wage unless the employee is provided with career counseling and information and referrals. The employer provides information about local self-advocacy, self-determination, and peer mentoring training opportunities, and provide this at least every 6 months during the first year of employment and at least annually thereafter. So we're really getting away from warehousing people with disabilities, of providing sub-minimum wage, of provider agencies operating businesses. The focus is intended that providers such as myself and you, that we are to assist people to be in the community, either participating in the community or have a job in the community. The definition of competitive integrated employment is very specific and is essential to understand where we're going as providers at this time. So we want our people, when we do find placements for them in the regular community, that they should be paid directly by employers, not through us as a provider, that they need to be on the provider's payroll, that it should be at a minimum or prevailing wages with all the benefits that other employees receive in this typical work setting where the employee has the opportunity to interact or has the opportunity to interact continuously with non-disabled coworkers, and is preferably engaged full time. So this is what our goal is. It's the expectation that we need to have, because in the prior types of service models, the providers weren't expected to have any more expectation rather than caring for people or getting them ready. So our expectations need to begin to change. The definition of competitive integrated employment also includes the broader goal of ensuring that youth and adults with disabilities are meaningfully engaged in the community and have access to individual supports for full participation. And for us, what that meant was, we were taking people out of institutions, and they were severely socially deprived. Many people didn't want jobs. They didn't know what jobs were because they hadn't been provided any opportunities to even be in the community, to have normal role models. They had a lot of behaviors that were antisocial because they learned those behaviors in the institution from other people with disabilities. There were no normal role models for them to emulate over the course of their life. So we had to really start at the beginning and to provide opportunities for people with disabilities in the community. From there, looking at what their interests were and what skills they had, that's when we really began to focus on employment. And it's not necessarily 40 hours employment. I was in this one program in Illinois where this young lady was a quadriplegic. She was nonverbal. She could only move her head, but they discovered she could read. And they found some technical expertise to help them hook her up to a computer. And for a couple hours a week, she worked downtown in an integrated setting where she made labels. I believe it was for a florist, as they sold their goods to the community. And she had friends, and you could tell that she was happy, and her life was ever changed. So it's, finding job opportunities that fit people's interests and their skills. And it could be just for a few hours a week, if that's what meets their needs at that time in their growth process. So customized employment was also defined in WIOLA, and it talked about a different way to find people jobs, where it's an individualized match between the strengths, condition, and interests of a job candidate and the identified business needs of employer. And it's not necessarily the typical job that an employer may have advertised for. It's going into a business and understanding their needs. It might be task reassignment. And in later webinars, Jenny's going to talk a lot about this and how to do this as a provider. It could be carving out a job out of existing job descriptions. It could be 2 or more people sharing a job that a non-disabled person might normally fill by themselves, or it could be self-employment. We had this young man who had moderate intellectual disabilities, and mom wanted to invest in his future so that he could be independent after she was gone. And she began to invest in vending machines and with us help negotiate at various sites, at businesses throughout the community, places to put the vending machines. And her son came in and stocked them and replenished the money for change that was in the machines and created his own business. Future legislation. In 2015, both the Senate and the House, federal government, proposed legislation called Transitioning to Integrated and Meaningful Employment Act. And what it was phasing out segregated sheltered employment and Section 14C. That didn't pass at that time, but it was first introduced by both houses of Congress. In 2014 came the settings rule. And a lot of people have, providers have anxiety about the settings rule. And both Jenny and I in the next 8 months or so are going to help you through this about what it really means, how this is going to fit into the whole employment first concept. You know, this is just part of the whole evolution of moving services into integrated settings. So what Congress said in these new regulations about waiver funding was that by 2022 now, they changed the date, that funding for people using waiver, that these settings for service provision had to be in integrated settings and support full access to the greater community. So instead of being in a center, learning to cook in the center, maybe it's taking it out into the community, maybe at a junior college or a restaurant or some other setting where other people take cooking classes. The settings have to ensure individual rights of privacy, dignity, respect, and freedom from coercion and restraint, of course, optimizes autonomy and independence in making life choices, facilitates choice regarding services and who provides them, and we're going to talk in the next 8 months or so all about choice. Some providers have real challenges about the word choice and that providing people choices. So we're going to talk about that. What Medicaid is not going to fund is publicly or privately owned facilities that provide inpatient treatment on the grounds or immediately adjacent to public institutions, or have the effect of isolating individuals receiving Medicaid-funded home and community-based services from the broader community, which is, you know, the model that I inherited when I was the CEO, was pretty much totally segregated, and we isolated people. except for field trips. And when we talk about integration, we're not talking about field trips. We're talking about facilitating somebody's life in the community to the fullest extent possible, not random occasional visits to the community, but how to live in the community. In 2015, much like Rhode Island, there was another court decision. And it was pretty much the same thing, that the state was targeting people with intellectual disabilities, and when they left schools, they went straight into sheltered workshops. And the federal court said, you can't do this. And they closed the door to all their sheltered workshops, and they began moving people into integrated competitive employment and community engagement. What just happened this year in this session is both the House and the Senate have come up with pretty much the same legislation as what was proposed a year or two ago, of shutting down shelter workshops and getting rid of 14C certificates and sub-minimum wages in the future. So that hasn't been passed yet, but it's been proposed again. And this is by, both the Senate and the House. So you've got Democrats and Republicans working together to pursue this. So I think this is, destined to be passed sometime in the future. And there's 193 co-sponsors in the House and 30 in the Senate now that would, this is another bill, raise the wage bill, raising minimum wage from $7.25 to $15 over the next 15 years. It would get rid of 14C sub-minimum wage certificates and move the ball forward to full integration of people with disabilities. So what you have is over 50 years of steady movement towards full inclusion. We've got several different models, always of doing business that, a lot of people may think, what the institutional movement was really bad, or, maybe some people now think the center-based movement is bad. It was just a sign of the times. It's an evolution of, at one time these people got nothing. They were beggars on the street or they were locked up. And people began to search for ways to facilitate them having full lives. And as the time has gone on over the last century or so, we've learned how to do things better. And so we have a new way of doing business. And so this whole evolution brought us to Employment First. And Employment First is not litigation, it's not legislation, it's public policy that the federal government and many state governments have approved for moving forward. And it's a public policy and it's a fiscal framework where employment in the general workforce is the first and preferred outcome in the provision of publicly funded services for all working age citizens with disabilities, regardless of level of disability. So it's a philosophy of this is the expectation that we must have and provide vehicles for people to fulfill this expectation. Now, just like you or I, your mom, your dad had expectations for you. if they didn't have expectations for you, you probably wouldn't have been in this field. You probably wouldn't have had the education. You wouldn't have had the opportunities that make you you. So what it's saying is we need to have new expectations. And that under this approach, somebody needs to mute their phone, please. Under this employment first philosophy, states' publicly financed system are to align their policies, their regulations, their service delivery practices, change their rate structures, and commit to competitive integrated employment as the priority option for people with significant disabilities. So that's what you're seeing, and that's part of what this webinar series is about, is that the state of Alabama is aggressively trying to align their policy, come up with new regulations that can help providers facilitate moving in this direction and to change their reimbursement structures. So our new service model, the new philosophy, that the new expectation that we as service providers are to have is advancing competitive integrated employment infused with community integrated engagement. And as I said, our agency, while there was a handful of people that we could move immediately into employment because they had the interest and skills, we really focus a lot of our attention on community integrated engagement because so many of our people were so socially deprived. They had not been in the community. They didn't have the values, the norms, the social expectations that we needed to provide them opportunities to engage with non-disabled people to get those skills and so we could see what interests they had towards moving towards employment. It's not a movement that's going to happen overnight. You're not going to be able to do this in a year or two. You'll start the process. The first time we did this to flip our Washington, D.C. agency, it took us somewhere between 6 and 8 years to flip the entire agency. But as we got better at that, we in my last decade of being at the organization, we took over, for one reason or another, about a dozen other agencies. And we got to the point where we could flip an agency from center-based to totally community-based in about 2 years. So there's a path for you to do this. And you need to know that we're going to be there to help you and provide the techniques to do that. So from a national perspective, what's going on because of all this? Several states have already eliminated sheltered workshops. State governments are moving aggressively to support change and to support provider agencies as they transform rates, regulations, training. This webinar series is part of all that. And I know the state of Alabama is now currently working on new rate systems and regulations to facilitate your being able to change the community-based services. The federal government is supporting system change and is putting a lot of money and technical assistance into it. Change is occurring everywhere in the United States. Community-based services are developing across the country as the settings rule approaches rapidly. So the future, what to expect and what will be funded. Increased emphasis on community integrated work. Increased emphasis on community-based pre-employment training. Increased emphasis on community-based day services. Decrease of use of the 14C minimum wage certificates and decreased acceptance of segregated settings. Provider agencies need to, their expectation needs to change, that everyone can be a contributing member to the community, either volunteering or really having a real job of some sort, or just being in the community. There'll be significant changes in every aspect of your business model because you're really changing businesses. You know, you're just not adding a employment specialist to help facilitate job placement. You are changing your business model, which means you're going to transform instead of adapt. People who don't really accept that are going to linger. It's going to take you much longer to go through the process. And I know because I've gone through this, and when I first started, I did not want to accept this change. I was buying multi-million-dollar buildings. I had a large impact on a very big portion of Washington, D.C. I was very proud of myself. I was very young that I had all these buildings and all these people under my control. And it took a while for me to come to the notion that I was wrong. And I needed to facilitate what my staff had found out and what techniques they were showing me that we could do much better in improving people's lives. That assessment of your current business practice is critical, and we're going to walk you through assessment tools of how to look at your business. That leadership and planning is essential. You can have the best staff, the best ideas, but if the leadership, if the board and CEO are not supportive, you're not going to change. And essentially, over the long haul, I ended up taking over a dozen organizations in 5 different states because they were failing either programmatically or financially. So somebody like me is eventually going to take you over who has the better service delivery model. We've got workforce issues. We've got to do a lot of changes with our staff about how we hire, what their job descriptions are, how we train. A lot of work has to be invested in our staff. And resource reallocation. We're going to have to move, and it took me a long time to learn this lesson, that it's not a matter of just being more in the community. It costs more to be in the community. You have to have higher trained staff, more technology to be in the community. And the government, while they might change your rate and give you more money, it's going to pay for those services. It's not going to pay for the transition. And your building and all those support services in the center-based model cost a lot of money. This is where a lot of your resources are going now. So gradually over time, you need to move those resources into your new community-based model. Implications for people receiving services and their family. Expectations need to change. You know, there are a lot of families who are reluctant, they're maybe even frightened to have their child out in the community. We'll help you with ways to overcome that, to work with families, to come up with protocol so that families feel safe and secure for their child. Services are going to be targeted, individualized, decentralized, functional, and community-based. We need to provide training for families about their benefits. A lot of families are frightened that they're going to lose their SSI. We need to help them understand what the ABLE-Act is, where you can set aside a good portion of money that is not taxable, nor does it affect your benefits. And we'll talk about all that over time. And there's going to be increased acceptance of individuals in their communities because people are actually going to be in their community. The community-based service model, the impact and what we've seen is we're moving towards individual and small groups, and it's going to impact on people's identity and self-esteem. It's going to be more integrated in the community where they're going to have typical community role models, normal relationships that's going to help independence and social skill development. It'll be functional learning with right to risk, using the skills people have now, not what they're going to have 10 years from now. We're going to decentralize services with unlimited provider capability. When I was growing my agency, I could only be as big as my building was. And what I discovered was I could be in 5 states, and I didn't have to invest in any facility. And our reach was limitless. And now I believe my agency is in 2 additional states. We're in a place and train model, learning by doing. And people are going to have educated choices, not just choices. You know, I want to be here with my friends. I want to sit in the building and do nothing all day. That's not a choice because that's where a lot of people came from. We're going to provide educated choices for people where they can have dreams for the future. I'll tell you one story that made me really realize that, you know, Byron said that this webinar is recorded, and hopefully you'll be able to use this with your board members, maybe with parents, staff, in a variety of settings. I'm providing technical assistance in a variety of states, and I just met this one provider, not in Alabama, and they were very reluctant and didn't know how to go through the transformation process, which is normal. You know, if you don't know how to do something and somebody's asking you to change, you know, you're going to have some anxiety about it. But I went to their website, and on their website, they had a statement about how the federal government was mandating them to get everybody a job for 40 hours a week. And they were terrified that their people didn't have the interest, didn't have the skills, didn't have the endurance to do such a crazy thing. And it's like, no, the federal government is not asking you to do that. The federal government is saying if you're going to use their money, in the state of Alabama now is too, that you have to have the expectation and provide the stepping stones for people to have a real life in the community. And that's both integrated, competitive employment, as well as being engaged in the community as much as possible. And so that's where the transition is going. So that's the end of this particular webinar. And I believe the next one, Jenny is going to take you to competitive integrated employment and talk much more about that and how to do it. Does anybody have any questions now? You could unmute and ask me. Anybody? Well, you know, you all have my email address. There it is on the screen, and my telephone number. And for those agencies who are in the Employment First Technical Assistance Program, you know, and even if you're not, you know, feel free to send me an email or give me a call if you have any questions, either now or later as we go through this process.
Tom, are you going to email the PowerPoint? We got one person asking for a copy of the PowerPoint.
Yeah, I can do that. I've got, well, if they're part of the
They
group,
are.
yeah,
Share it with our board.
yeah, I've put together all the emails that you've given me as contacts,
Yes.
and I can email that PowerPoint to everyone. But
Okay.
remember too, this is recorded, and so, but I think it's pretty straightforward to where you could walk